So, hi friends, good morning. I'm Dr. Anshul Bansal, again joining you on this Unacademy platform. In today's YouTube live session, we'll study about the top 10 most important topics for the INICET and the FMG. So, these are the top 10 topics जो बहुत बहुत important है, and in every competitive examinations one or two questions are asked very frequently from these topics. Okay, so we'll study about these topics very quickly in this lecture. So this is a rapid revision type of session for you, especially for the INICET and FMG going students for this year. Okay, so I'm currently working as an orthopedic house surgeon in SMS Hospital Jaipur, and I have cracked the NEET PG examination last year, that is in 2020 only. So let's start this session, and before starting the session I will just briefly guide you about a various subscription plans that are available for the NEET PG on Unacademy. The first one is your plus subscription. The plus subscribers will get access to all live as well as recorded classes. They will have access to the entire QBank, and they can compete in live tests and quizzes, all of which is formed by the topmost faculty for the NEET PG in India. And also we'll allow the subscribers to study on any device of their choice at any time by allowing them to log into multiple devices with the same account. And also for the subscribers who will be subscribing for 12 months or more, we are shortly providing them with a printed notes. And while subscribing, you can use my code, that is Anshul B10, to get extra 10% off. The second one and the best one is your iconic subscription, and it is best not only on the Unacademy platform but across any digital platform for the NEET PG in India. And what makes this best is that apart from the things that I've told you earlier, in extra May you will get the prep ladder and all of the prep ladder, including all of its Q banks, the video lectures, the rapid revision courses, grand test, quizzes, etc. Everything you will get. And on Unacademy Extra May you will get the well structured live batch wise classes, and we have structured our courses and formulated our batches in such a way so as to build a basic concept about any subject or topic first, then going into its in depth. And also after every test that you give, the iconic subscribers will get an individual test assessment sheet so that they can analyze themselves, yes, this topic or this subject needs more revision, or what are the things that are asked more frequently, or what are the things that I have left, yeah, that is lagging behind. So all this is very important in planning and analyzing your preparation, and all of this is available for the iconic subscribers. And while subscribing for the course, you can use my code, that is Anshul B10, to get extra 10% off. Now special classes are very special. I always ask these learners to take this special class and attend this special class, because they'll give you extra edge over your competitors. And also they are live interactive classes which will give you classroom like feeling. You can interact with your educators, clear your doubts there and there only. You can participate in polls, you can watch it anywhere anytime. But what you have to do, you have to just download the mobile application of the Unacademy application, and log in using my code, that is Anshul B10, and both of which are absolutely free. And also after every special class that you'll attend, you will be provided with the digital notes of that class. And you should subscribe for QBank, because it not only contains 25,000 plus questions, but also quality wise it is the best QBank, because it contains everything that is necessary for your examination. Every type of question, including the entire theory type of questions, the recall questions, high yield MCQs, previous years MCQs, the image based questions, the x-rays, CTs, MRIs, the clinic loaded in in a QBank. So you can subscribe for. Okay, okay, I'm back online. Okay, so let's start. three topics which are very important, and this year also you had three questions from single topic of arthritis, that was ankylosing spondylitis. So first we'll study about the ankylosing spondylitis, and also differentiation between osteoarthritis and rheumatoid arthritis is very important. So we'll study these three things in the arthritis, and next we'll study bone tumors. Very important. Har saal at least one or two questions are asked in every competitive examination, and here also three topics are very important from which repetitively questions are asked, and these topics are, first of all, GCT or the osteoclastoma. This year in NEET PG 2021 also there was one question from GCT. Then osteosarcoma and your Ewing's sarcoma. Okay, so six हो गए. Now metabolic bone diseases are also very important. This year in NEET PG there were two questions from this topic, and here we'll study again three topics, that is rickets, osteomalacia and scurvy. And the last topic that is again very important, her examination में at least one or two questions are asked. This year NEET PG also there were two questions from this topic, that is the nerves of the limbs. उसमें भी nerves of the upper limb is the most important. So we'll study about the आज के लेक्चर में only the tests and the palsies of the nerves. Okay, so these are the top 10 important topics that we'll study today, and in 10 topics में से at least you should think कि 6 to 7 questions will come from these 10 topics only. Okay, so very important lecture. So firstly we'll study about the arthritis. So arthritis are of three types. First is the osteoarthritis. Osteoarthritis is of two types, that is primary and secondary. जो primary होता है, it is the most common type, and we'll study orthoarthritis as a primary osteoarthritis only. It is a natural process which occurs in the old age, elderly age, generally after 70 years of the age. Okay, and it is progressive but a slow onset and slowly progressive. Whereas secondary osteoarthritis में क्या होगा, there is a precursor bony disease or bony injury or bony lesion which leads to the osteoarthritis of the joint. So this is rapidly progressive, occurs in a young age group, and the diseases that are present is can be a old fracture, intra-articular old fracture, or immobilization in cast for a long time. Okay, or there can be arthritis due to sepsis or osteomyelitis, etc. So many diseases can lead to secondary osteoarthritis. Septic arthritis, नाम से पता चल रहा है, it will be infective. Now inflammatory arthritis, that is chronic inflammatory conditions में, it can be due to some autoimmune diseases like the rheumatoid arthritis or the psoriatic arthritis, or it can be due to crystals, gout and pseudo gout. So remember, great toe कहीं पे भी आ जाए, then it is gout, and gout में there will be monosodium urate or monohydrate crystals, but remember calcium and phosphorus के salts नहीं होंगे. Okay, it will be urate. Whereas in pseudo gout, pyrophosphate crystals will be there, but in the form of calcium salts. Okay, so ये बहुत important है. Now आज के three most important topics about the arthritis, उसमें से we'll start with the rheumatoid arthritis. Okay, so rheumatoid arthritis जो होता है, it have a diagnostic criteria कि out of these things, if 4 or more symptoms or signs are present, then you can diagnose it as the rheumatoid arthritis, which is morning stiffness, polyarthralgia, 3 or more joints, symmetrical swellings, rheumatoid nodule, rheumatoid factor positive, and the X-ray changes. Okay, Now there is a genetic predisposition, and you just need to remember one name, that is HLA-DR1 or HLA-DRW4. This is the HLA or the histocompatibility markers associated with the rheumatoid arthritis, and some viruses, Epstein-Barr virus का नाम you need to remember, which is important with the, or which is associated with the rheumatoid arthritis. Now the basic pathology में difference होता है in the rheumatoid arthritis and the osteoarthritis. The rheumatoid arthritis में the disease begins, or the basic pathology is in the synovial membrane. There is hypertrophy or inflammation of the synovial membrane starting में, and this hypertrophied synovial membrane will lead to the formation of a special structure called as pannus, and this pannus will grow and it will destruct the entire joint space. Okay, so rheumatoid arthritis में synovium will be affected first, leading to the formation of the pannus in the joint space, whereas in the osteoarthritis the main pathology is in the articular cartilage. Okay, so synovium is not affected here. Here the affected part is the synovial cartilage, and this cartilage के destruction से there will be loss of joint space, leading to the arthritis and destruction of the joint. So सबसे पहले we'll study about the rheumatoid arthritis. Now ankylosis means bony fusion, यानी जो दो joints होते हैं, the joint space is obliterated and there is fusion. So it can be of again two types. First of all, it will start as a fibrous ankylosis, then it will convert into the bony ankylosis. Okay, remember that. And so arthritis में सबसे पहले in rheumatoid arthritis pannus formation होगा, the joint space will decrease. Okay, and there will be destruction of the joint, there will be subluxation, then dislocation, etc. Okay, and also x-ray में you will have a very important finding, that is your periarticular osteopenia. Okay, very remember periarticular osteopenia or periarticular osteoporosis. Here you can see in x-ray there is subluxation with joint destruction. Okay, here you can see the joint is disrupted, subluxate, and there is this periarticular osteoporosis or osteopenia, a typical x-ray of the rheumatoid arthritis. Okay, now most commonly it is seen in the 20 to 50 any young adult age group. Sorry, that too in the women. Okay, very important, women, because it is an autoimmune disease, that's why it is more common in the women. And remember इसमें तो arthritis होता है, it is polyarthritis, यानी 3 or for 4 or more joints, यानी more than 3 joints are involved at least. So polyarthritis, this polyarthritis is acute and symmetrical. Remember, this polyarthritis is an acute arthritis and it is bilaterally symmetrical. There is morning stiffness, and यहाँ पे morning stiffness lasts for more than 1 hour. Okay, and the most commonly joints affected is your metacarpophalangeal joint. The metacarpophalangeal joint, that is the MCP joint, is the most common joint affected, and bilaterally, and that too कौन सा most commonly of the index finger, thumb के पास वाला finger, that is your index finger, it is affected most commonly, and there will be stiffness, pain, etc., all the signs of the acute inflammation. And remember, MCP joint is the most commonly joint affected, but here in rheumatoid arthritis, DIP, that is your distal interphalangeal joint, this one. Okay, this is your metacarpophalangeal joint, this is your proximal interphalangeal joint, and this is your distal interphalangeal joint. So remember, rheumatoid arthritis में DIP, that is a distal interphalangeal joint, is never involved. Okay, ये बहुत बहुत important है, बाकी सारे joints involve हो सकते हैं, but DIP is never involved. Now this is a typical rheumatoid arthritis में late stage में क्या presentation होता है hands में. So here you can see there will be thumb में there will be boutonniere's deformity, and rest of the fingers at DIP there will be swan neck deformity. So fingers में DIP पे swan neck deformity, thumb पे there will be boutonniere's deformity, and at the metacarpophalangeal joints, which is the most frequently associated, वहाँ पे there will be ulnar deviation. वहाँ पे there will be ulnar deviation. So this is a typical feature of a rheumatoid arthritis में late stages के अंदर the picture of the hand. So remember this, very important. This is your boutonniere's deformity where there is flexion at the PIP and extension at the DIP. Okay. This is hallux valgus, seen in case of great toe in rheumatoid arthritis. And in rheumatoid arthritis, here you can have the hammer toe where only the PIP is affected, claw toe, both PIP and DIP are affected, and the mallet toe, like the mallet finger, where only DIP is affected. Okay, so this is your typical picture of the rheumatoid arthritis, where you can see that there is joint destruction. Okay, severe arthritis with joint destruction of the interphalangeal metacarpophalangeal joint as well as your wrist joint, with subluxation of various joints, with periarticular osteopenia. Okay. And now rheumatoid arthritis, as we have studied, it is an autoimmune disease, so there will be some systemic features also, or extra articular manifestations, and इसमें से most important is your vasculitis leading to the arteritis, Raynaud's phenomena, mononeuritis, multiplex, etc. So rheumatoid nodules, again very important. We'll see the pictures of this in the later slides. Most common site is your oligrenon, ये ध्यान रखना है आपको. And other systemic features will be serositis, like in the lung and the pleura, heart में pericardium, eye में iridocyclitis, etc. So you all have studied it in the medicine. So rheumatoid arthritis में, here are your rheumatoid or rheumatic nodules, most commonly seen in the oligrenon, like this. Okay. Now, in the blood investigations, the ESR CRP will be elevated, hemoglobin will be less, and you go for the rheumatoid factor. Now, rheumatoid factor क्या होता है? Rheumatoid factor is the antibody formed against the IgG antibody. Autoimmune है, so auto means खुद की टिश्यूज या कुछ खुद के एंटीजन, सेल्फ एंटीजन के अगेंस्ट देयर इज ऑटो एंटीबॉडीज लीडिंग टू द डिस्ट्रक्शन ऑफ द host tissues or the self tissues. So it is an antibody directed against the IgG immunoglobulin or antibody of the human, and इसमें भी its FC part. Okay, so this is your RF, that is rheumatoid factor, and this antibody that we measure or detect in the human serum, the RF factor, it is the IgM antibody directed against the IgG antibody of the patient. Okay, so very important. And remember, RF factor positive is not 100% confirmation of rheumatoid arthritis, whereas also all patients of rheumatoid arthritis do not have positive RF factor. Okay, remember this. And this RF factor in the serum can be detected by various tests, जिसमें अपन IgM antibody को ही टेस्ट करते हैं. It can be latex fixation test, the Rose Waller test, and the biopsy also. Okay, now differential diagnosis में SLE. So remember, SLE में जो acute polyarthritis होता है, it is not symmetrical and also not ankylosing, and here you have the anti-nuclear antibodies or and the absence of the anti-nuclear antibody factor. Okay, so remember. And osteoarthritis slowly progressive होगा, older patients में होगा, DIP joints will be affected, and there will be no systemic features. So differentiation between the osteoarthritis and rheumatoid arthritis is very important, that we will discuss now. Okay, so osteoarthritis, as I have told you, the main pathology will be that intra-articular cartilage, whereas in rheumatoid arthritis it will be the synovial membrane. Very self-explanatory and easily understandable from the image. And here also osteoarthritis, the intra-articular cartilage is affected, and in rheumatoid arthritis pannus will lead to the destruction of the entire joint. Now rheumatoid arthritis की late stages में typical hand features we have seen. Similarly in osteoarthritis late stages में this is the typical feature that you will see. And what you will see that there will be fusiform swellings at the joints. So there will be Heberden nodes or nodules at the DIP. Okay, there are two types of nodules. At the DIP there will be Heberden nodes, whereas in the PIP there will be Bouchard's nodes. Okay, so Heberden nodes and Bouchard's nodes both are seen in the osteoarthritis. Plus at the DIP there will be radial deviation, and metacarpophalangeal joint is not involved, as we have seen. वहाँ पे metacarpophalangeal joint पे there were ulnar deviation in rheumatoid arthritis, whereas at the DIP there will be radial deviation in case of osteoarthritis with Heberden nodes and the Bouchard nodes. Okay, so this is your arthritis. This is a normal joint with normal joint space, smooth. Here you can see osteophytes with decreased joint space and arthritic changes. Okay, so differentiation between the both very important. सबसे पहले rheumatoid arthritis and osteoarthritis later in life होता है, slow progressive होता है, and osteoarthritis, whereas rheumatoid arthritis इसका opposite. And rheumatoid arthritis we study, it is symmetrical, polyarthritis bilaterally symmetrical, and यहाँ पे osteoarthritis is asymmetrical, starting में monoarthritis, then we can change to the polyarthritis. And also polyarthritis more than 4 or at least 4 joints. And rheumatoid arthritis में most commonly involved joint is the MCP, metacarpophalangeal joint, and DIP will never be involved, whereas osteoarthritis में large joints are involved first, and most commonly involved joint is your knee, hip, wrist and the other small joints. Now morning stiffness दोनों में होगी, but we have discussed that rheumatoid arthritis में it will be more than 1 hour, and there will be no systemic symptoms in case of osteoarthritis. Okay, so in general rule of the law ऐसे याद रख लो कि osteoarthritis will have more signs and symptoms, more intense signs and symptoms. Osteoarthritis is the most common form occurring in the elderly. So the and it is osteoarthritis is also called as the wear and tear disease. Wear and tear disease is called as the osteoarthritis. Okay, now age of onset more than 15 osteoarthritis होता है. Pain both in but morning stiffness and inactivity में pain is more in the rheumatoid arthritis. The joint characteristic में क्या होगा, rheumatoid arthritis is the autoimmune disease, so there will be soft, warm and tender joints, whereas in the osteoarthritis they will be hard and boning with no movement at all. Okay, now we'll come to the treatment. So treatment जो होता है सबसे first is acute phase में आपके पास patient आया है, you have to give the NSAIDs etc. You have to go for the acute management, and then you that is called as the remission. And after remission with the DMRDs, that is disease modifying anti-rheumatoid drugs, you go for the maintenance so that this acute phase does not come back. And in the entire process you have to go for the physiotherapy and some prophylactic splints etc, so that there is no pathological fracture, there is no deformity. Okay, so medical treatment में NSAIDs we have seen in the acute stage, as well as DMRDs, and DMRD of choice in rheumatoid arthritis is your methotrexate. And इसके अलावा कौन सी और DMRDs है, just open your pharma notes, pharmacology notes, and sorry, it will take just 5 to 10 minutes and read the DMRD. Steroids obviously you can use. Now in orthopedic treatment, it is generally for the prevention of the deformity and the joint functions and the rehabilitation. So the most important is your physiotherapy and cold fermentation, hot fermentation. Generally in arthritis we go for the hot fermentation. And rehabilitation and operative methods में you can go for the preventive, palliative or the reconstructive surgery. So preventive surgery में क्या होगा, अगर rheumatoid arthritis है, there is large pannus formation and it is destructing the joint, you can go for the synovectomy. In palliative surgeries, where you need to change the joint, but it cannot be done due to some other systemic diseases, or the patient is not fit for the surgery, having other complicated diseases due to old age, etc. Then you can go for the bone block operations or the tendon lengthening surgery. And the treatment of choice for the last advanced stage of arthritis, where the entire joint is destructed, there you have to go for the reconstructive, that is the joint replacement, total replacement surgeries. Okay, now again, very important is your ankylosing spondylitis, also called as the Mary Trumpel disease. And I always tell you कि ankylosing spondylitis आते ही you need to click two things. First is it is HLA-B27 positive, okay, and secondly bamboo spine, yani dagger sign. There will be bony ankylosis of the entire axial skeleton, especially of the spine, and it begins from the most commonly affected or first affected is your sacroiliac joint. Okay, remember this, very important. It is most commonly seen in the young age groups, 20 to 30-year-old males, young adults, and 20 to 30-year-old males. And the classical presentation is the stiffness with pain, and iske pain mein there is a characteristic feature, okay, that the stiffness and the pain will increase when the patient is doing rest. Okay, so there is a typical presentation of morning or late night pain and inability to have a good sound sleep. Okay, so rest may it will increase, whereas if you do the work or if you do the movement, then the pain will decrease. Okay, so very important feature. And the stiffness will start from the sacroiliac joint. In the later or the advanced stages where bamboo spine is set in, then you have the kyphotic deformity of the spine, and it is a autoimmune disease, and also it will have a many systemic symptoms. Okay, autoimmune disease hai, so it will have many systemic symptoms, and these are okay, and the systemic symptoms are the reactive arthritis of the other joints, especially the knee joints, etc., reactive uveitis of the eyes, and the reactive iridocyclitis. Okay, these are the three systemic most important. इसके अलावा fever, etc., are common. And another very important is its association with the ulcerative colitis. Okay, you just need to remember this. Now there will be stiff back and stiff spine with loss of lumbar lordosis. And test के लिए very important test, first is your pelvic compression or the sacroiliac compression test, and another very important is your Ganslin's test. Okay, this is the picture of the Ganslin's test done for the sacroiliac joint testing for suspected ankylosing spondylitis. SLR test also you can do, and the pump handle test also you can do for the sacroiliac joint. Now for the cervical spine के involvement के लिए you have a special test called as the Fletcher test. In case of cervical spine involvement in ankylosing spondylitis, you will not be able to stand straight and touch your occiput occiput wala region with the wall without lifting your chin. Okay, so this is your Fletcher test. And thoracic spine involvement के लिए और costochondral junction का involvement हो गया, उसके लिए you go for the chest expansion test. Okay, so these are the tests. This is your dagger sign with bamboo spine. Okay, and here you can see the sacroiliitis may start. Okay, there is inflammation here. Okay, and x-ray of the lumbar spine may you will have the squaring of the vertebra with loss of lumbar lordosis, and there will be bridging osteophytes like this, which is called as the syndesmophytes and the bamboo spine. Okay, now treatment. No specific therapy, physiotherapy as well as the NSAIDs etc. are the most important drugs that I use. So indomethacin is effective, physiotherapy, and recently you can go for the monoclonal antibodies also. Okay, so this is about the ankylosing spondylitis and other arthritis. Now bone tumors mean two things are very important. First is your GCT, and so three things बहुत important है: GCT, osteosarcoma and the Ewing sarcoma. सबसे पहले we'll study about the GCT, that is giant cell tumor, also called as the osteoclastoma, but it is misnomer because नाम से पता चल रहा है in GCT you will have the giant cells in histopathological pictures, but these giant cells are not osteoclast. So this osteoclastoma is a misnomer. Giant cell tumor is a benign tumor, but it has a special feature of recurrence that makes this tumor as well as its treatment very important. Okay, so microscopically you will have the multinucleate giant cells with highly vascular tumor. मोस्ट कॉमन प्रेजेंटेशन इज योर 20 to 40 years एज ग्रुप, एंड इसमें आपको एक चीज याद रखनी है दैट इन जीसीटी द प्रेजेंटेशन विल बी आफ्टर द फ्यूजन ऑफ epiphysis. Okay, GCT will present only after the fusion of epiphysis. This is very important. Generally in the young adult age group around the knees, most commonly involved part is your proximal tibia and the distal femur, and इन दोनों में से भी एक चूज करना पड़े, go for the proximal tibia. Now tumor is located at the epiphysis. Now इसमें भी there is controversy. The most correct answer is your metaphysis epiphysis junction. But if you are said कि कहाँ पर है, so the location is your epiphysis. There can be pathological fracture, and on x-ray or the examination you will see a tumor like swelling at the respective joints, and that is a eccentrically located swelling, not in the center of the bone but eccentric, giving a soap bubble appearance. We'll see the characteristic image. Okay, here you can see that this is giant cell tumor, and here it is eccentric place, soap bubble appearance, and remember it will never break the cortex of the bone. Okay, so this is your typical GCT. This is your histopathological slides of GCT, where you can very easily see the multinucleated giant cells. Okay, now multinucleated giant cells जो होता है, it is also present in one more tumor, and that tumor is your chondroblastoma. In chondroblastoma also you have a scattered multinucleate giant cells. Okay, now diagnosis, there will be first of all the as we have seen in the image, lytic lesion, but it will be solitary, only single lesion will be there with loculated and eccentric location, subchondral, and it is a expansile lesion. Okay, it will expand but not pierce the cortex. Soap bubble appearance will be there, and there will be no calcification, no periosteal reaction. very important, there will be no acute inflammation के signs, that is redness, pain, tenderness, etc. Okay, and it does not enter the adjacent joint. Now treatment is the excision of the tumor with or without arthroplasty. Okay, so it depends on the site of the GCT, the GCT is of which bone. Okay, now we'll see here, if the GCT is of the lower end, that is distal ulna or the proximal fibula, you don't need both these parts for any function. So only excision is the treatment of choice. Whereas in case of other GCTs at the other side, you have to go for the reconstruction processes by the turnoplasty or the fibular grafting, etc. Okay, so remember this is very important. And now iske alawa, yeah, you can have do this curettage with or without supplementary procedure, that is the bone cementing most commonly used. Other, you can use the cauterization or the cryotherapy. And इसमें the most common drawback, most important drawback is its high recurrence rate. Okay, so to eliminate this factor, after curettage you do the bone cementing. So not only the bone cement will give the support and fill the void after the excision, but also the heating effect of the bone cement will destroy the remnant tumor cells. Okay, so bone cementing with curettage, another very important method. More aggressive, repeated, recurrent tumors, yeah, you need to do the amputation. And if it is of the spine, GCT of the spine, it is managed with the radiotherapy. Okay, now the second most important is your osteosarcoma, which is the primary malignant tumor osteosarcoma, called as the osteogenic sarcoma. Okay, so the most common metastatic tumor of the bone is your the most common malignant tumor of the bone is your metastasis, whereas most common primary malignant tumor of the bone is your osteogenic sarcoma or the osteosarcoma in the young adult age group. Okay, so uh, it is a pathology of the mesenchymal cells, and it is of two types, that is primary and secondary. Primary, like in primary osteoarthritis only, primary mein there will be no pre-known malignant situation condition of the bone, but it will be in the young adult age group and it will be rapidly progressive, and it is the commoner of the two. So now we'll study only about the primary osteosarcoma. In exam maybe if you get anything about osteosarcoma, consider it as the primary. Secondary, as the name suggests, there will be some pre-malignant bony conditions like the Paget's disease, endochromatosis, dysplasias, history of the radiations to the bone, etc. It is in the older age group, that is 45 years onwards. Now on the basis of histomorphology, it can be of the osteoblastic type, chondroid cartilage, fibroblastic, or the telangiectatic or the osteolytic type, and this type has the worst prognosis. Okay, the telangiectatic type or the osteolytic type of osteosarcoma has the worst prognosis. Okay, metastasis is very common, which is through the hematogenous route, and most common site in the first site is your lungs, and lymph node involvement is unusual. More malignant होगा osteolytic type में. Age of onset 15 to 25 years of the age, and commonest site of the origin. Now this is very important. Commonest site of the origin is your lower limb, and it may be the distal femur and the proximal tibia are the most common sites, and it arises from the metaphysis. Okay, so remember O for osteosarcoma. So M के बाद N से there is no tumor, but M then O. So मेटाफाइजियल से जो भी स्टार्ट होंगे दी ट्यूमर्स, दे विल बी जनरली ओ, लाइक osteosarcoma, osteoid, osteoma, etc. Okay, so these are your osteochondroma. So it will be metaphyseal in origin. Okay, now the gross appearance, it generally depends upon the histomorphic pathomorphic type that we have seen. But अगर कोई कुछ भी specified नहीं हो, then you have to consider is at the most common type, that is your osteoblastic type, which is grayish white, hard and gritty feeling on cutting. Chondroid or the cartilage type will have the bluish gray appearance. Fibroblastic, fish flesh like. Now most malignant will be your telangiectatic type, where there will be tumor necrosis in the middle. Okay, and histopathology mein you will have the tumor malignant cells, which will have the anaplastic mesenchymal cells. And remember, all the cells will be not of the same shape. Okay, so there will be pleomorphism. Pain is usually the first symptom. Okay, metaphysis in origin hoga. And here you can see this is a typical X-ray finding of the osteogenic sarcoma, and इसको पहचानने के लिए you just need to see the periosteal reaction as seen here. So this periosteal reaction of the periosteal new bone formation is the typical features. It is seen in many other conditions in the orthopedics, but such an intense and irregular periosteal reaction is seen only and only in case of osteosarcoma, whereas in rest other the periosteal reaction is not so intense. It does not migrate or involve the soft tissues to such a great extent, and they are regular. But here it is irregular. Okay, so this is your osteogenic sarcoma. It can be lytic, sclerotic, or the mixed pattern. You can see the pleomorphic cells with mesenchymal anaplasia. Okay, here you can see the gross, where you can see the grayish white and the hard, and this is your tense looking बहुत बड़ा large tumor at the distal femur with no redness, warmth, etc., no sinuses, etc. Okay, now there will be destruction of the metaphyses, and the cortex will be breached, and there will be involvement of the soft tissues, metastasis, and the involvement of the joint. So periosteal reaction we have already seen, and after, in the initial phase of the periosteal reaction, you will have the subperiosteal newborn formation in the form of Codman's triangle, and this is seen in case of Ewing sarcoma and other diseases with periosteal reaction also. The not specific, just you need to remember. And this typical periosteal reaction that we have seen, this is called as the sun ray appearance or the sunburst appearance. Remember, very characteristic and important for the osteosarcoma. Okay, the sun ray or the sunburst appearance. The serum alkaline phosphatase will be elevated. Biopsy is the sorry, confirmation के लिए. Here you can see the intense periosteal reaction, the sun ray appearance. This is your Codman's triangle. Okay, now histologically में the pathognomic feature will be your new bone formation, that is your periosteal reaction. Okay, and lung is the earliest site, as we have discussed here. Okay, now treatment of choice. Treatment of choice is your amputation, remember. Okay, treatment of choice is your amputation. But after amputation also there are slip areas. Slip areas is that after removing the tumor part also, there are high chances that some tumor cells has migrated to the other parts of that limb. So these are called as the slip areas. To destruct them and to remove them, you go for the chemotherapy even after the amputation. But in recent times and nowadays, due to earlier diagnosis as well as more newer techniques, the treatment of choice is now your limb saving operation. So you can plan a limb saving operation where you just resect or excise the tumor with the normal border be lekin. Okay, and you can then go for the reconstruction or the prosthetic implants, etc., for the limb saving surgeries. Okay, so the recent trend is towards the limb saving surgery. So amputation remains the mainstay, and the margin for the excision that is taken, it is the 10 centimeter margin. Okay, remember this thing, very very important. Treatment of choice in case of spine is your radiotherapy. Okay, in case of spine. So level of amputation, if it is lower end of femur, mid thigh or hip disarticulation, upper end of the femur, hip disarticulation, or the hind quarter amputation. Okay, so amputation. Role of chemotherapy, nowadays we give the chemotherapy for the slip areas or these micro metastasis के control के लिए. Okay, so we go for the chemotherapy, and nowadays immunotherapy with sensitized lymphocytes is on the development phase, and in some countries it has also been started for the patients also. Now prognosis is poor. 5-year survival rate with surgery alone without any chemo is only 20%. Okay, now secondary osteosarcoma with pre-malignant bone diseases hoga less malignant as compared to primary. Older age group after 40 years mein hoga. Okay, so this is your osteosarcoma. Okay, एक periosteal osteosarcoma भी होता है, which is in the region of the periosteum. Okay, here you can see this is your periosteal osteosarcoma. Okay, now Ewing sarcoma. Ewing sarcoma, another very highly malignant and important bone tumor seen in the young adults, but age group is more younger than the osteosarcoma. Okay, and the most common affected part is your pelvis. But if it is in the long bones of the lower limb, that is the distal femur, proximal tibia, etc., are the most affected part. And ये ध्यान रखना, जैसे M के बाद N से कोई ट्यूमर नहीं होता, M के बाद O आता है, वैसे A B C D के बाद there is E, so it is diaphysis. अगर long bones में है, so remember it is diaphysial. Okay, and gross pathology is, it is will be more vast with more large area, and there will be areas of necrosis in between or soft areas of the necrosis. Okay, grayish white but pus like. So pus like yani there will be fever. So there is an important DD for the Ewing sarcoma, that is your osteomyelitis. Okay, so there will be fever in case of Ewing sarcoma. And histopathology में क्या होगा, there will be now वहाँ पे pleomorphic, यहाँ पे there will be uniform cells which resembles to lymphocytes, and these cells are managed or located in a pseudo rosette format. Okay, so there is a pseudo rosette where you have a series of these tumor cells like this, and in between the tumor cells what will be there, there will be this necrotic material here. So this is called your pseudo rosette. Okay, flat bones, the lytic lesions, and here is your pseudo rosette. Here you can see pseudo rosette, the lymphocyte like cells, tumor cells with a area of necrosis. This is the gross of the Ewing sarcoma. There will be periosteal reaction here also, but it will be not that intense and irregular. There will be no sun ray appearance. Okay, यहाँ पे onion peel appearance होगी, which we will learn. Okay, so fever hoga, other symptoms are same, and lytic lesion, mid shaft, that is diaphysis, and onion peel appearance, and cortical destruction will be less as compared to osteosarcoma obviously. So here the periosteal reaction जो होगी, it will be regular in form of layered, which is called as the onion peel appearance. Okay, now chronic osteomyelitis से differentiate कैसे करेंगे, there will be sequestrum, cloaca, etc. in case of osteomyelitis, but not in case of Ewing sarcoma. And very important. Now this is highly radiosensitive tumor, so radiotherapy is the treatment of choice here, but there are high chances of recurrence. Okay, there are high chances of recurrence. Prognosis is very poor, more poorer as compared to the osteosarcoma. So this is a Ewing sarcoma, lytic lesion with layered or regular periosteal reaction. Okay, now we'll come to the metabolic bone disease, very important, and here we'll read about the rickets, scurvy, osteomalacia, and also osteoporosis is again very important. हर साल एक question osteoporosis से आता ही आता है. This year also there was one question of the osteoporosis. So in submit two another very important topics apart from the 10 topics that we will cover today are osteoporosis and your osteomyelitis, okay, which we have not covered in this lecture. Okay, so you should go and read them. It will just take 10 to 15 minutes. So there are generally four types of metabolic bone diseases. Okay, there are four types of metabolic bone diseases. First of all is your osteopenic. Osteopenia में क्या होगा? There will be, in osteopenia, the mineralization of the bone will be normal. Okay, so calcium and phosphorus salts का जो mineralization होता है, it will be normal, but there will be loss of bone matrix. Okay, there will be decrease in the bone mass. Bone mass will be decreased. There will be loss in the bone matrix, and the typical example is your osteoporosis. Whereas in osteosclerotic diseases, नाम से पता चल रहा है, there will be sclerosis, यानी there will be increase in the bone mass, and fluorosis is a typical example. Now osteomalacic यानी osteomalacia, so there will be decreased bone mineralization. Okay, so the organic matter is under mineralized, and characteristic example is the osteomalacia and the rickets. Whereas the mixed type, where it will be osteopenic as well as osteomalacic, it is your hyperparathyroidism, and characteristic feature of hyperparathyroidism is your brown tumor. Remember, okay, is your brown tumor. Now there are three things, three important hormones that are related to the calcium, serum calcium maintenance, and these are the vitamin D. Vitamin D जो होता है अभी, you just need to remember that vitamin D, serum calcium and phosphorus दोनों को it will increase, calcitonin will decrease both serum calcium and phosphorus, whereas parathormone will increase the bone resorption, so it will increase the serum calcium level, whereas it will increase the excretion of the phosphate in form of urine, or secretion of the phosphate in form of urine, so the serum phosphate level will decrease. So in high rickets or osteomalacia, where there is vitamin D की deficiency, so there will be decreased in serum calcium as well as serum phosphorus in case of rickets. Whereas in case of hyperparathyroidism, serum calcium will increase but serum phosphate will decrease. It is in case of hyperparathyroidism. Whereas in case of osteoporosis, serum calcium and phosphate are normal. Very important. In case of osteoporosis, these will be normal. Remember these things, they are very important. So rickets and osteomalacia, they are the deficiency of the vitamin D or the cholecalciferol. In children it is called as the rickets, whereas in adults it is called as the osteomalacia. Okay, remember. Now vitamin D metabolism is very important. It is in the skin, and from the UV rays it is activated to form the 7-dehydrocholesterol, where it go for the hydroxylation first in the liver, then in the kidney, and this 125 dihydroxycholecalciferol जो होता है, it is the active form of the vitamin D. Very important, remember this thing. Okay, and it is formed in the kidneys. Now rickets बच्चों में विटामिन डी डेफिशिएंसी, so obviously बच्चों में the skeleton is growing skeleton, so there will be disturbances in the growth of the bone, so the growth plate will be affected because vitamin D deficiency osteomyelitic disease है, so there will be failure or of normal mineralization, or there will be decreased mineralization of the bone matrix. Okay, so it is of type 1. Type 1 rickets is your vitamin D deficiency wala, so vitamin D dependent rickets. Okay, so here if you supplement the child with vitamin D, you can see that the symptoms are not worsening, the x-ray images etc are improving. तो vitamin D dependent rickets is your type 1. Type 2 में rickets में vitamin D की जगह जगह के साथ साथ there is deficiency of the phosphate, so alone giving the vitamin D supplementation will not improve the symptoms. Question this year was on the type 2 rickets. Okay, so this is due to deficiency of phosphate, so it is called as the phosphatemic rickets. It is called as the type 2 is called as the phosphatemic rickets. Okay, now clinical features very important hota hai, and generally the age of presentation is 1 year old. Okay, and there will be craniotapes, ping pong mechanism of the skull, the bossing of the skull, the broadening of the long bones, Harrison sulcus. Okay, there will be जो diaphragm होती है at the lower chest, at the insertion of the diaphragm there will be a horizontal depression like this. Okay, this is your horizontal depression called as the Harrison sulcus. Okay, now pigeon chest, that is the sternum will be prominent, and in rickets you will have the rachitic rosary. Rachitic rosary is the costochondral junctions जो होते हैं, they will be prominent here. This is your rachitic rosary seen in case of rickets. Okay, there can be muscular hypotonia, pot belly, and deformities, and the most common deformity is your knock knees or the bow legs. Here you can see the knock knees or the bow legs. Now radiological features, very important question, इसी पे ही आएगा, बहुत important in orthopedics. So the earliest radiological features and the typical most common radiological features are seen at your wrist joint. So in a suspected rickets patient, you need to go for the x-ray of the wrist joint, that is the lower or the distal ends of the radius and the ulna. So obviously there will be no mineralization, growth plate will be affected, so there will be delayed appearance of the epiphysis, and there will be widening of the epiphyseal plate. So generally it is 2 to 4 mm with cupping of the metaphysis. Here you can see this is your epiphysis, this is your metaphysis. Okay, this is your epiphysis, this is your metaphysis, and in दोनों के बीच पे there is this growth plate which is called as the physis. So here you can see the area is increased, there is cupping, this is called cupping of the metaphysis, with ends में there will be splaying of the metaphysis, destruction of the growth plate. Okay, so delayed appearance of the epiphysis with widening and cupping of the metaphysis. Okay, and normally जहाँ पे metaphysis and ये meet करता है, there is a sclerotic line called as the zone of provisional calcification, but it is absent in case of rickets. Okay, this zone of provisional calcification, there will be cupping and splaying of the metaphysis as seen, and bone deformity, knock knees etc. So here you can see that there is bowing of the legs with cupping and splaying of the metaphysis. Okay, very important, these x-rays are very important. Here you can see widening with cupping and the splaying of the metaphyseal area, very important. Okay, do remember these things. Serum calcium will be normal or low. Most commonly it will be low. Serum phosphate will be low, and serum alkaline will be high. Okay, remember this thing, it is again very important. Now treatment is giving vitamin D supplementation. So initially जो single dose होती है, it is of the 6 lakh international unit. Then you go for the maintenance phase of 400 international unit every day. Okay, so first 6 lakh international unit, then maintenance में 400 per day. And after giving this 6 lakh international unit, you can see the healing in the x-ray. Okay, so there will be that line of sclerosis at the metaphysio epiphyseal junction pe. And if 3 to 4 weeks of the maintenance dose mein this line of sclerosis is seen, that means you are on the wrong path. Sorry. And if after 3 or 4 weeks of this 6 lakh wali dose also there is no line of sclerosis, then you can give this 6 lakh wala shot once again. And even if there is no response after the second dose, it is called as the refractory rickets, where you need to investigate properly and find the cause. Okay, now orthopedic treatment is required for as a prophylactic measure for any pathological fracture or any deformity, etc. Okay, so bow legs are the characteristic features in case of rickets, and you have a specially diagnosed splint for that, for the knee deformity, called as the mermaid splint. Okay, here you can see this is your mermaid splint for the knee deformities, especially in case of rickets. Very important, just remember the picture. And sometimes if deformity of set in and severe deformities are there, then you have to go for the corrective osteotomies. Okay, osteomalacia, same like rickets, same cause, that is vitamin D, but it is seen in case of adults. Okay, and the bone is demineralized, and it is generally seen in case of parda symptoms like in the Muslim women, etc., because sunlight is very important for the metabolism of the vitamin D. It will be converted into the hydroxy cholesterol and then to the active form, and the initial process that is required is through the UV rays. Then there is hydroxylation. So UV rays and sunlight is very important for the vitamin D activity. So that's why parda system, etc., will lead to higher chances of osteomalacia. So there will be bone pains, weaknesses, waddling gait, and even tetany in severe cases. So this is your typical waddling gait seen in case of osteomalacia. Okay, now investigations में radiology में in osteomalacia as well as rickets, but more pronounced in osteomalacia, you will have a typical loser's zone, also called as the pseudo fractures or the milkman lines. Okay, milkman lines, pseudo fractures, or the loser's zones, or also called as the cortical infections in osteomalacia and rickets. Here you can see this is your loser zone here. Okay, so loser zone is a translucent line traversing like in the picture. So just remember your picture and the different names seen in osteomalacia and the rickets. In females, you will have the triradiate pelvis and the protrusio acetabuli. Okay, this is your protrusio acetabuli. You can see in the pelvic ring it is protruding, and this is your triradiate pelvis in case of females. Biopsy, and in serum again calcium will be low, phosphate will be low, and alkaline phosphatase will be raised. Okay, now treatment is same, that is 6 lakh international units, then maintenance with the 400 international units. Now scurvy. Scurvy is again very important, and scurvy is due to deficiency of the ascorbic acid, that is vitamin C. And vitamin C is related to the formation of the collagen, which is again related to the wear and tear and healing. So there is either production is decreased or the quality is not good. So a typical presentation of this scurvy will be a swollen gum, gingivitis, abnormal bleeding, pateki, etc. And in orthopedics, there will be uh, involvement of the bones, and the first bones that are involved is of the lower extremities. It is of the lower extremities, and there is a typical feature of this scurvy, especially seen in case of infantile या बच्चों की scurvy में, and this is a typical feature of this scurvy, which is your subperiosteal hematoma. Okay, that is your subperiosteal hematoma, and there will be scorbutic rosary also. A typical वहाँ पे rachitic rosary थी the costochondral junctions पे, but it is not this scorbutic rosary is not the prominence of the costochondral junctions. They are the calcified subperiosteal hematomas. Okay, they are the calcified subperiosteal hematomas. Here you can see this is your scorbutic rosary. Now rickets ka x-ray is very important, because here you will have some typical features like we have seen in the rickets. वैसे ही some typical features, sorry, यहाँ पे scurvy का x-ray is very important, जहाँ पे you will have a typical features of this scurvy, like वहां पे क्या था, that line of sclerosis or the provisional calcification was lost, but here it is becomes more prominent, and it is called as the white line of Frankel here, and it is the characteristic feature of this scurvy at the epiphyseal metaphyseal junction. There will be rounding off of the epiphysis called as the Wimberger sign, and there will be Pelkin lines or the Pelkin spur like at the edges of the metaphysis. वहाँ पे you will have this splaying and cupping of the metaphysis. Here you will have the Pelkin spur. Subperiosteal hemorrhages होंगे. There will be this white line of Franken जो होता है dense zone of provisional calcification के ऊपर. There will be a thin black line which is called as the scorbutic zone or the tumor field zone. Okay, and there will be ring epiphysis or rounding of the epiphysis called as the Wimberger sign, and this is the Pelkin spur. Okay, so white line of Frankel, Wimberger sign, white line of Frankel, tumor field or the scorbutic zone, subperiosteal hemorrhages, and the Pelkin spur. These are the characteristic features of the scurvy. Remember, very important. And इसके अलावा there is 4 H's of the scurvy, which are the hemorrhage, hyperkeratosis, hypochondriasis, that is the emotional changes, etc., and the hematological abnormalities. Okay, so very important. Now 9 topics, very important, we have covered: rheumatoid arthritis, osteoarthritis, ankylosing spondylitis, GCT, osteosarcoma, Ewing sarcoma, rickets, osteomalacia, scurvy. Now, last topic for today will be the nerve tests and the nerve palsies of the upper limb, which are very important. In upper limb mein, you have 3 nerves that you should study. First is your radial nerve, second is your median nerve, and third is your ulnar nerve. So सबसे पहले we'll study about the radial nerve. So radial nerve आते ही, the one thing that should click in your mind is posterior. Okay, so this radial nerve arises from the posterior cord. It traverses and supplies the posterior compartment, that is, it supplies the extensor compartment or the posterior compartment of the forearm. Okay, remember this about the radial nerve. Okay, so first of all, radial nerve जो होती है, it will supply to the triceps. Triceps को check करने के लिए triceps का action is your extension. So elbow को fix करके you will ask the patient to do the extension and the elbow, and by feeling here you can feel the contraction in the triceps, which will be absent in case of radial nerve palsy. Okay, brachioradialis again, what you need to do, you need to fix the elbow, and from 90-degree onwards in the mid prone position you will do like this. Okay, stand out like this, and here you can feel that there is the prominence or contractions in the radiobrachialis. And the typical sign of the radial nerve palsy is your wrist drop, because the wrist extensors will not work, so there cannot be the extension of the wrist, so there will be wrist drop. Okay, and most common fracture which leads to this wrist drop is your fracture of shaft of humerus, that too at the junction of the middle one third and the distal one third, called as the Holstein Lewis fracture. Okay, wrist extensor. Now extensor digitorum, that is which extends the digits or the fingers at the metacarpophalangeal joint. Okay, metacarpophalangeal joint. So there will be finger drop also, but it is like this, not like this. Why? Because the finger का जो extension होता है at the interphalangeal joints, it is done by the lumbricals, which is not by the lumbricals, which is not supplied by the radial nerve. Okay, remember this. Now extensor pollicis longus of the thumb, interphalangeal joint of the thumb mein there is extensor pollicis longus, so it is also supplied by the radial nerve. Okay, so on keeping the hand on the table, you ask the patient to extend the interphalangeal joint, which will not be possible. So in case of radial nerve palsy, so this is your triceps testing in radial nerve palsy. Brachioradialis we have already seen. Okay, now the radial nerve injury or palsy, it is known by various names. Just remember the name: Saturday night palsy, honeymoon palsy, handcuff neuropathy, crutch palsy, and your squash palsy. Now this is very very important, and इसमें भी सबसे important is this is your sensory supply of the upper limb, that is your dermatome, or the skin supply, not your myotome. दोनों में difference होता है. Dermatome, so here are three colors: green, blue and pink. Okay, so this is your anterior part, this is your posterior view, and just remember कि कौन सा part किस nerve का है, and then learn them, very very important. So that green thing, green is supplied by the ulnar nerve. The blue one, it is the median nerve, and the pink one is the radial nerve. Okay, remember this is very very important. Now we'll come to the median nerve. Okay, so median nerve, remember, it supplies the flexor compartment of the forearm, except, very very important, except flexor carpi ulnaris and medial half of the flexor digitorum profundus, both of which are supplied by the ulnar nerve. Okay, these two are supplied by the ulnar nerve, remember this. Okay, so मीडियन नर्व बाकी सारी फ्लेक्सर्स को सप्लाई करेगी, तो फ्लेक्सर पॉलिसिस लॉन्गस, जैसे एक्सटेंसर पॉलिसिस लॉन्गस था दी थंब में इंटरफेरेंजियल जॉइंट, वैसे ही थंब इंटरफेरेंजियल जॉइंट में फॉर द फ्लेक्शन यू हैव द flexor pallidus longus. So you will not be able to flex the thumb like this. Now flexor digitorum superficialis and the flexor digitorum profundus का lateral half को test करने के लिए you have a very important sign. से radial nerve में wrist drop था, वैसे ही median nerve में there is the pointing index or called as the Ochsner's clasp index. Normally you can do like this. Okay, but in case of median nerve palsy, due to this flexor compartment muscles, these two muscles के paralysis, you will not be able to flex the finger, so it will be like this. This is called as your pointing finger and the pointing index or the Ochsner's clasp index. Now remember कि medial half is supplied by the ulnar nerve, so इसलिए apart from the index and the middle finger, other like this little finger or the ring finger, you can flex these fingers. Okay, so remember this is very very important. Flexor carpi ulnaris में on wrist flexion or the palmar flexion. If there is a median nerve palsy, then your wrist will deviate towards the ulnar side. Okay, this is your flexor carpi ulnaris. Now muscles of the thenar eminence, very importantly, thumb में it is supplied by the median nerve. Three muscles होती है thenar muscles, which is the abductor pollicis brevis, the opponens pollicis, this is your abduction, so abductor pollicis brevis, opponens pollicis, and your एक और होती है, that is your, okay, first is your abductor pollicis brevis, second is your opponens pollicis, and third is your adductor. Okay, so remember कि जो median nerve है, it will be lobe. Okay, it will be lobe. L for lumbricals supplied by the median nerve, and that to the first and the second lumbricals, yani thumb and the index finger की. O for the opponens pollicis, A for the abductor pollicis brevis, and third for the flexor pollicis. Okay, flexor pollicis. So see, flexor pollicis longus को टेस्ट करने के लिए you have this test which we have already discussed, pointing index of the Ochsner's clasp index. Flexor carpi radialis we have discussed. Abductor pollicis brevis के लिए you have the pen test like this. Okay, pen test like this normally. Very important in this year's NEET PG. Straightforward image based question था pen test पे, due to the abductor pollicis brevis and the median nerve. Very important. Now due to the wasting of the thenar muscles, you will have the ape thumb. Okay, and you will have the benediction hand. What will happen in the benediction hand? Due to the loss of flexion, the these ring finger and the middle finger may you will not be able to flex them, so this is your benediction hand. Okay, seen in case of median nerve palsy. Now last is your ulnar nerve. It supplies, अपन ने देख लिया, the third and fourth lumbricals, the palmar and the dorsal interossei, and flexor carpi ulnaris, and the medial half of the flexor digitorum profundus. So flexor carpi ulnaris को टेस्ट करने के लिए you do the palmar flexion, and if there is palsy of this muscle, of this nerve, or there is paralysis of this muscle, the wrist will deviate towards the radial side. Okay, abductor digiti minimi. Okay, abductor digiti minimi like this. Okay, the interossei, remember pad yani palmar interossei will do the adduction. Pad and dab, palmar interossei will do the adduction like this. So here you have the palmar interossei को adduction को check करने के लिए you have the card test, where normally you can hold the card like this, and also for testing the dorsal interossei, that is the abductors, you have the Igawa test of the middle finger. Okay, this is your Igawa test. Okay, this is your Igawa test to test the abductors, that is dorsal interossei, and the adductors palmar interossei के लिए you have this card test. Okay, you have this card test. lumbricals में isolated action या test नहीं कर सकते. Third and fourth lumbricals supplied by this. Now abductor pollicis brevis by the median nerve, whereas the adductor pollicis is by the ulnar nerve adductor, and इसके लिए you will have the Froment sign or the book test. Okay, very easy to see. Normally what will happen, that you can hold a book or a card with straight thumb, but in case of ulnar nerve palsy, there will be paralysis of the adductor pollicis, so you will not be able to hold this without flexing this DIP. So this is your Froment's positive. So this is your Froment's positive and this is your normal. Okay, important for the ulnar nerve. Now you have two types of claw hand. First is your partial claw hand, जहाँ पे you have the single isolated only ulnar nerve palsy, whereas in the complete there will be ulnar as well as median nerve palsy. Okay, so this was all about today's lecture. Top 10 topics we have discussed in a rapid revision form. I hope you liked the video. So again, very happy Diwali to all of you. Stay safe, and INICET and FMGE aspirants, just don't waste your time. INICET के लिए only 10 days are left. It is very easy, it is crackable. Okay, don't need to worry. Thanks for watching my lecture. If you like the lecture, please like, share and subscribe, and use my code, that is Anshul B10, while subscribing on any of the packages for the Unacademy. Okay, so